Sir, yes, first slide. You please give the first slide, sir. Yes, yes,
Okay.
yes. Let me introduce you, sir, first. Okay, good evening, dignitaries, and good evening, Ankur, sir. So, we are highly
Hello.
privileged to
Good
have
evening.
Dr. Ankur Bhattacharya with us today. He is Assistant Professor, Department of Medical Oncology, Dr. B. Bodua Cancer Institute, TMC, Guwahati, and he has done his specialization from B. Bodua itself. So we are highly privileged that today he is with us and he will be giving the presentation. So with this, sir, I would like to request you to say, give your presentation.
So very good evening. Ponmata elaborately giving introduction. Thank you for that. And actually, it's my pleasure that I am here to present this important presentation that is metastatic hormone-sensitive prostate cancer. It's actually privilege, and thank you, Bear, for that opportunity. So, should I start the presentation?
Yes, sir. Yes, sir.
Yeah, yeah. Okay. So coming to the hormone-sensitive prostate cancer, whether it is metastatic or non-metastatic, the main backbone of the treatment is always ADT-based treatment, and the further treatment based on whether we need the accelerated response, accelerated control, whether the patient is capable of taking higher-end molecules, whether patient is fit enough to take the medications, the cancer therapies, whether the patients are fit to comply with the treatment protocol. There's so many factors we have to consider whenever we try to start with the treatment protocol. Especially in those metastatic settings when our main target is to control the disease, we always have to check whether it is high risk or low risk, whether it is high volume disease or high volume and low volume, we always formulate the treatment. Like in a very high volume disease, always the three-line treatment is always required with the inclusion of docetaxel based chemotherapy. And if it's a low volume disease, or metastatic disease, yes, we can consider with the we can skip the chemotherapy arm along with the one androgen receptor inhibitor with the based protocol. So if we go ahead with the treatment paradigm, we can say that it is moving from the chemo-based regimen to the chemo-free regimen in nowadays. So if we go ahead with the history part, then we see that in Charted and Stampede, where ADT and docetaxel were used, which is gradually changed to abiraterone with Latitude and Stampede. And with the advent of the Titan and RRCs, we can move ahead with the apalutamide and enzalutamide based regimens. And now the treatment era has been changed. So although it is pronounced a little bit differently, so still I would like to proceed with the terminology that it is a change of era. So probably it is era sense, it is era note and era sec, which I personally believe. So now the advent of the darolutamide, the treatment landscape has been changed. It is highly acceptable to all our patients. It is safe kind of, although we have used in a very few number of patients, but the results are really amazing. And I will share about one patient which has taken currently darolutamide and showing amazing response in subsequent presentation or end of my presentation. So the moving ahead with the presentation, yes, we have a very unmet need because the metastatic hormone sensitive prostate cancer, the terminology can be changed to metastatic hormone resistant, castration resistant in a very small time, like in 1 year or 2 year, if the patient is not responding to the conventional treatment approach. So the Erasens already showed beneficial efficacy and safety profile in metastatic HSPC, leading to its approval in India 2023. But daltamide combined with the ADT would provide efficacy benefit in chemo-free settings. Whether it is actually feasible or not, that we are going to discuss in our presentation. So the ERA-NOTE study, it is a randomized double-blind placebo-controlled phase 3 study where it is darolutamide is along with the ADT is combined with the ADT alone. They are actually trying to study whether patient can be put on longer remission, delayed subsequent line of therapy with a chemo-free regimen. So here the 665 patients were included and blinding was done as 2 is to 1 and it's open label study and darolutamide with there is feasibility of crossover to the darolutamide arm with the comparator arm. So obviously the primary endpoints were OS, time to initiation of the subsequent therapy, time for CS, CRPC, time for PSA progression along with the quality of life and deep PSA response less than 0.2 nanogram per ml. That are the objectives. The main highlight was the real survival, and the selected endpoints mainly was OS and safety after the crossover. So if we see the basic characteristics, demographic and clinical characteristic, it is surprisingly, and I'm happy that the trial included a majority of Asian population. If you go by the all trials, they almost exclude Asian population and Indian populations. But in this study, it is very beautiful. Asian populations are included. And de novo metastatic disease and recurrent disease both are included, whereas the high volume cases are majority, that is around 70% were the high volume cases. So the China, India, Taiwan, Australia, and New Zealand both equally represented as by regional data, and it is highly uh, beneficial for the all communities pertaining to the variability in the patient selection. Especially the Indian population inclusion is a very wonderful thing. Now coming to the first primary objective, that is the radiologically assess the progression-free survival, and it is clearly shown that after 2 years, around 70.3% patients still not progress. That is an amazing result compared to the comparator with ADT, that is only 52%. And if we go by the volume of disease, it is clearly shown that high volume disease responds better compared to the low volume disease, and the uh, PFS is almost kind of double compared to the placebo. That is 19.2 months in comparison. That is 13 months in the darolutamide arm. And coming to the OS also, that we demonstrated its OS benefit and the time of hormone sensitive to the hormone resistant part, that is also improved. In fact, in darolutamide arm, it is not yet reached compared to the placebo arm, that is 13.8 months. And similarly, the PSA progression is also 16.8 in comparator arm compared to the high darolutamide arm, it is still not reached. So we can safely say that the ADT with darolutamide causes a benefit not only in the PFS, also in the OS, RPC, time of PSA progression in every sector. Now coming to the delayed time to CRPC and time to pain progression, it is seen that in the hazard ratio 4, that is showing that 60% of the patients still in the darolutamide ADT arm has not go for is leveled as a CRPC, and it's a wonderful thing that of 60% are still hormone sensitive after end of 2 years. And if we consider the pain progression score, it is also significantly uh, lower in case of downtamide and ADT arm, and the hazard ratio is 0.72. It is another important factor in the study. Now, coming to the deep and durable PSA response, actually, the downtamide ADT arm, the importance that it is not important to reduce the PSA. The importance is to produce a deep response. If we reduce the PSA level less than 0.02 nanogram per ml for a longer duration, actually it is a achievement for our clinicians. So in this study, it is shown that the 62% of the population still had response, and the PSA level is 0.2 nanogram per ml anytime during the treatment. So PSA level is also uh, lower in case of downtopic and ADTR, and hazard ratio is only 0.31. So in the whether it is high volume or low volume disease, we can expect an equal result. In high volume also, the comparator arm is not showing any benefit in 24 weeks, 36 weeks, 48 weeks, everywhere the ultimate and ADT arm showing the better results. And similarly, in the low volume disease also, they are showing the promising results. Now coming to the subsequent line, uh, okay, there is a technical apology for that.
Yes, sir, no issue. Tech team, please help, sir.
Yes, sir.
Just a minute. Is it visible now?
Yes, sir, it is totally visible now.
Yeah, yeah. Okay. So if we go ahead with the life prolonging systemic therapy after the dialtamide ADT failure, it is showing that only 32% of the patient is required to do so, while in placebo arm it is 42%, which is also an important factor. Now coming to the treatment-related adverse effect, yes, although dialtamide is safer compared to the other ARIs, but still it is a little bit higher in comparison to the placebo arm. Obviously, because of that, we are giving two drugs comparison to the one drug. But the grade 3 and grade 4 toxicity is only marginal. It is 0.5% is less. And treatment-related death are less in comparison to the placebo arm. Although the number is showing 21, but if we go by the percentage, it is only 4.7% compared to the 5.4%. So yes, the uniqueness of the deltamide that it crosses blood-brain barrier very minimally, so we can expect the less CNS toxicities compared to the other ARIs. So, although it is not a head-on comparison, but still we can formulate that the fatigue part is not that much in case of deltamide and ADT arm compared to the placebo, which is only 5.6% in comparison to the other only ADT arm, that is 0.5%. But if we see the other comparison with the other ARIs like enzalutamide and apaltamide, yes, fatigue we see in case of like around 20 to 30% of the patients in day-to-day practice. So the adultamide extended median time of deterioration to affect total score by 5.1 months versus placebo, which is also a good predictor that the patient is having quality of life on treatment, and it is also important for the patient of the CF prostate that the majority of patients are elderly, and a little bit of improvement in the quality of life that is also important in clinical day-to-day practices. So coming to the conclusion of the study, it is clearly evident that the altamide and ADT significantly improved the radiologically derived PFS in patients with metastatic HSPC, and it showed a benefit across all the secondary endpoints, whether it is OS, whether it is sustained low PSA level, and also increased duration to the next subsequent treatment. In every sector, it is showing benefit. Daltamide was associated with deep PSA response regardless of baseline PSA level, and it is also the first and only AR inhibitors to demonstrate clinically meaningful delays in, yes, pain progression, overall well-being, including social, family, functional, and urinary symptoms compared to the others. And it has a very favorable safety profile. So with or without docetaxel, yes, we can administer. And on final conclusion, what we can conclude that if the patient is having high volume disease, if the patient is fit enough, then should certainly proceed with the triplet agent. But in those patients who are not fit for chemotherapy, who have in poor ECOG status, yes, darolutamide plus ADTM can provide a very good result compared to the ADT alone. And I would like to share one patient also who recently been shifted from apaltamide to daltamide, and with a PSA drop of approximately almost 90% is within 2 months, which is also a very promising result for us. So with that, I would like to conclude the presentation, and thank you everyone for listening.
Thank you. Thank you very much, sir, for this wonderful presentation. I would like to thank you from our buyer group, and it's a great privilege to have you with us, and looking forward to you in near future for such wonderful presentations. So it is really very nice knowing it from you that your patient is doing good with darolutamide. So with this, I think that you will be getting some confidence with our Darutomate definitely when the practical usage of Darutomate gives you such type of confidence.
Certainly. Yes,
Uh,
certainly, certainly.
so sir, one thing I just wanted to know from your end, just given situation, what are the criteria you generally thought, or what are the situation you generally keep in consideration while using Darutomate? If a patient comes to you in the first line, do you consider Baraltamide? Or if you consider, then why do you consider Baraltamide?
Factor which creates a barrier is the cost. Otherwise, that we always incline to give it the first line. And also, my personal recommendations will always be the Daltomate with the first line treatment. And we have seen in
I can,
all
yes, sir.
the
Yes, sir.
clinical discussion with the internal here. Our socioeconomic status actually doesn't permit. That is the biggest issue. And if somebody someday if it is the prices coming down like in other airlines, certainly we will consider it as a first line in every setting.
Yeah, yes, I can understand, sir. This is the conversation every time we go, sir. And
Yes.
recently, you have given one patient in the railway also. He is also railway. So in that regard, also I am thankful to you because you have considered
Okay.
Darultamide in that case. Those who will get the reimbursement from the government. So so with this, I would like to thank you for your presentation once more. And if there is any question from the, so I think there is no question. So thank you very much, sir. Okay, sir.
Thank you.
Good
Thank you
night.
so
Good
much.
night. Good
Thank you so
night. Good
much.
night.
Yeah. Good night.